Compared to our men, very much a very active group compared to the, we provide an exactly comparable service to men, which is a much quieter kind of place. So the ladies definitely were a lot more fun and a lot more active. And they really, for all the drama, because the men just do not have the capacity for drama that the women do. So you have to either love the drama or you can't work effectively with the women. It's absolutely, it is fabulous and very fun. So we did an evaluation. We used our own data. When we collect a fair bit of data on an ongoing basis, we were also able to use the data from our partners in the programs, the Canadian Mental Health Association and the Shepherds of Good Hope, who provides the space that we're in. And so we were able to combine all of that data. Plus, we did the usual kinds of stuff. We did focus group with clients, and we surveyed staff, and we surveyed stakeholders, all of that kind of stuff. So we really wanted to know, did we actually achieve what we were supposed to achieve? Which obviously that's a good thing. And who did the program serve? And is the profile of the women served consistent with what we wanted to do? And the reason we wanted to do that was because, I don't know if it's the same thing here, but Ottawa's notorious for having programs that are going to serve the hardest to serve, and then they want to take all the nice people. People are too sick for them to serve. So we wanted to make sure that we were actually serving the people who everybody else would consider to be too sick to serve. We wanted to know whether the partnerships between the organizations were really effective in creating that integrated approach to care. Like, did people really feel like it was one team taking care of them, and the plan was really the best one possible? And we also, everything we do, we always have to look at the cost of care. That's people in Ottawa, I think, because we're so close to the federal government, are inordinately interested in money. So why we did this? Well, we have a process. We have, I think, 7 residential programs right now. We try to evaluate them every kind of 2 to 3 years. This was the first evaluation for this program. But one of the reasons that we do that is because we have an expectation that we will get better at our business as time goes on. So we have, for every outcome that we have, for example, improvements in mental health care, we have a benchmark for every program. So this is what we expect to achieve. So it's important to evaluate ourselves regularly because, understandably, we should get better at what we do over time, and so we should be changing the benchmark periodically. But in this program, we didn't actually, I think we did have a benchmark by this point in time, but we want to look at, do we actually learn our business better? And it's always really, it's always easy to do evaluations and talk about the wonderful things that you do, but myself, I think it's more important to do evaluations and talk about what you're not good at, because that's what really helps you to make changes. So the results. So the program works. That was good news to everybody involved. And 90% of the women who were admitted, and we did an evaluation for 2 years of data, were permanently housed, despite the fact that none of them had been successful in housing previously. So that's pretty good. We do serve who we want to serve, and we've remained consistent with our values, and the clients and the staff said nice things about all of that, so that was great. And the costs of care are quite favorable when compared to other treatment options. They're extremely favorable when you consider the reduction in criminal justice costs and unnecessary hospital costs and that sort of thing. But just overall, you'll see it's a relatively positive kind of thing. So I don't want to go through all the data with you because you're probably better at this than we are anyways, but I just want to show you. So in 2007, 2008, which was the first year that the program was in operation, and arguably you can't evaluate much, you can see that on 3 of the measures, we were kind of getting better. So the first one is cooperates with, basically it cooperates with any of the medical care requirements. And so, so that's the blue line. So you can see that it got somewhat better between admission and discharge. So, did people let us take their blood pressures? Did they let us do dressings? Did they let us do that? So you can see that, yes, those kinds of things got better. Were we successful in treating them for the condition that we admitted them for? And you can see that, yeah, 40% of people actually got, and when we say successfully treated, we mean the standard of care for all Canadians. So did they actually adhere to that and successfully complete that? And you can see they didn't do too badly. And did they take their medications as prescribed? Then you can see that by 2010, you can see we've gotten really good, because at helping them be really good. So you can see that it actually is a lot better. And these things are important to us, not necessarily because they're a reflection of how good we are as healthcare providers, but because these are things that our people need to live independently and healthy lives in their own housing. And so these are things that are, you know, really important for us to work with people on because they're a good indicator of future success. And making people healthier is always good too. So you can see the difference between the initial ability to stabilize chronic medical conditions, and we've gotten so good at one of the reasons we've gotten so good, I can't really take much credit for this, but we've always had a psychiatric nurse practitioner and a mental health nurse. And so, you know, they chase people down and engage with them and see them, and people do extremely well on treatment. And our psychiatric nurse practitioner, who was amazing, retired. And so the hospital, the Royal Ottawa Hospital, which is our big tertiary care psychiatric hospital, in their wisdom decided to replace our psychiatric nurse practitioner with their associate chief of psychiatry, who's fantastic. But more importantly, all the doors to the hospital, all the programs at the hospital that we could never get anybody into before, of course, we can now get people into. So the quality of care, the availability of services to our population is just hugely different than what it was when the program opened. And so did we follow our values? And this is actually a quote from one of the frontline staff. And we asked both our own frontline staff that work in the program and the frontline staff from other organizations who work with us. And everybody said that, yes, this is clearly, you know, clearly this is the thing to be doing, that it really is a chance to engage with women and change things with them and to really have a positive impact on their lives. And it is amazing. I'm sure you guys see the amazing stuff all the time, but it is amazing. Sometimes I wish you could take a picture when you first meet somebody and then take a picture later. And actually, I do have one of those pictures. I'm just going to digress and just tell a tiny little story. We had a lady who was an icon in the community and very, very famous for all kinds of behavior. And I was at the Concurrent Disorders Treatment Banquet. So there was a banquet for people who are in the Concurrent Disorders Treatment Program. And I saw this lady sitting at the table where a lot of our ladies were sitting. And I knew I recognized her, but I couldn't think of who she was. And she was just beautifully dressed, beautiful hair, like just absolutely done up to the nines. I could not figure out who she was. And then I was in the washroom and she comes out of the other stall and I looked at her and I was like, oh my God, you're, she told me I can say this, Lori. And she's like, yes, I am. I didn't think you recognized me because you didn't speak to me. I said, I honestly didn't recognize you. My inside voice thought, because you have clothes on, because she was famous for taking her clothes off on the corner of Edward and Murray and doing the chicken in traffic. Like, I was just like, oh my God. So, you know, she was in house. She'd been in housing by that point for about a year. She was doing really, really well. She had a cat. She was going to the library, you know, all the usual kinds of stuff. So I actually took out my BlackBerry and took a picture of her washing her hands in the washroom, as girls are known to do, and sent it to, like, she said, I said, oh my God, like, I have to take a picture because it's unbelievable. She said, well, send it to everybody. And I did. I sent it to everybody who knew her because nobody would ever have recognized her. It was unbelievable. And the lady. So when we did our evaluation, we decided to use housing as the only evaluation measure because we knew that, you know, we get paid to make people healthier. So we knew from our own data that we were making people healthier. And it was really important for us to understand a little bit more about what the predictors of housing success are for women who are living in these kinds of circumstances and to be able to improve our orientation to really supporting them. So one of the things that was useful about this evaluation was that this is multinomous scores, and the multinomous scores are done by the Canadian Mental Health Association workers, so we never really see them, and they're always individually in people's patient files. So it wasn't until we brought them together that we were actually able to see a pattern of, so what's different about this population? So the difference for this population is that the multinomial, I think probably people will know what it is. It's a validated tool that measures people's functional capacity, people with mental illness, functional capacity to live in the community. And these are extremely low multinomial scores. So this is a population, 50% of the people here would qualify for an ACT team. So this helps us understand why these ladies are having such difficulty in being able to negotiate the traditional system, the system of care, why it is that they need a different kind of approach to care. So this was really useful to us. The good thing that you can see from baseline to current is that people's scores are actually improving. So it does certainly show us that people do have the capacity to change, and that the supports and the services that we're providing to people does actually improve their functional capacity. And so what predicts success? So from our data,